Hello everyone, welcome to Physio TV. Today we begin with a series of stroke rehabilitation talks. The topic for today is stroke rehabilitation in low middle income countries and the need for multidisciplinary team and evidence-based practices, which will be presented by Dr. Jairaj Pandian. And our moderator for today, Dr. Shyamala Pazare ma'am, who's a professor at CMF College of Physiotherapy, Pune, who's a PhD scholar, a yoga trainer, and was presented the best researcher in 2018. Over to you, ma'am.
Thank you so much for your kind introduction. So at the outset, I am thankful to the team of Sancheti Institute for giving me this opportunity. It's really an honor to moderate the session by such a senior and experienced person, Dr. Jairaj Pandian sir. The academicians and the researchers in the field of stroke rehabilitation are well versed with the work and contribution by him. We have been referring to numerous papers by him during the academic teaching as well as during the clinical work. So, sir at present is a principal and professor of neurology at Christian Medical College, Ludhiana. Apart from his DM and MD, he has various honors including fellowships from various organizations, associations like FRACP, FRCP, FESO, Fellowship of World Stroke Organization, then FNAMS, FIAM. He is at present Vice President of the World Stroke Organization and also the President of Indian Stroke Association. He was a proud recipient of the award, Global Stroke Services Award, which was given to him by World Stroke Organization in 2020. He is a member of World Stroke Organization Policy and Research Committees. He was a past chair of World Stroke Campaign Working Group of World Stroke Organization. Sir has served for 2 terms as Board of Director in World Stroke Organization. He is Editor-in-Chief of renowned journals like Journal of Stroke Medicine and Journal of CRISMED Journal of Health and Research. He is an editorial board member of International Journal of Stroke. He is a keen researcher and is a principal investigator of INSTRUCT. INSTRUCT is Indian Stroke Clinical Trial Network. His special interest is working into stroke care services, stroke trials, and systems of care. He has published widely on stroke, thrombolytics, stroke systems of care, then epidemiology and rehabilitation in low and middle income countries. And his today's talk is focused on the same topic. So I invite Dr. Jairaj Pandian sir for his talk.
Yeah, thank you. Yeah. Thank you, Dr. Shyamala Pazare, and thank you for inviting me for this program. It's a very innovative program by which you'll be able to cover so many of the people, students and other faculty across the country. So. Can you see the slide?
Yes, sir.
Yeah, okay. So what I'm going to do is I'll quickly talk about the burden of stroke, global burden as well as the burden in India, and then take you through the concept of stroke unit care and multidisciplinary team, and also what are the challenges in establishing stroke rehabilitation in developing countries like India, and what are the models available by which we can implement the stroke rehabilitation services, and also pragmatic, simple trials to answer our own questions. So this slide shows the latest data on global burden of stroke. Globally, 12.2 million new cases occurred in 2019, and 101 million prevalent cases, and about 6.5 million stroke deaths. If you look at the absolute number of incident strokes, it has increased by 70%, and the prevalent stroke has increased by 85%, and the death has increased by 43%. So it's a huge increase in burden of stroke globally, and the burden is greater in low and middle income countries. And this slide shows the world map, the heat map. And if you look at the incident rates across the world, the red, brown, and yellow are the very high incidence rate. India comes under slightly light blue, dark blue. And if you look at the Africa, some large part of Asia, you have a very high incidence of stroke. And what are the risk factors for stroke? Again, this is from the Global Burden of Disease Study. Hypertension is the #1 risk factor globally, whether you are in India or any other country. The #1 risk factor for stroke is hypertension. So what is the stroke burden in India? We have many incidence studies and prevalence studies done in India, but incidence is 119 to 152 per 1 lakh population. And the number of people who die after 1 month of a stroke ranges from 22 to 42% in our country. And this is our data from Ludhiana Urban Population-Based Stroke Registry. The age-adjusted incidence rate is about 130 per 1 lakh population, and 22% of the patients die in 28 days' time. And we did a similar population-based stroke registry in rural Ludhiana in about 148 villages. And what we found was the incidence is higher in rural Ludhiana as compared to urban Ludhiana. So it's close to 200 per 1 lakh population. If you look at overall state-wise burden of stroke, and this is the prevalence of stroke, you see the east coast of India. It is the prevalence ranges from 550 to 624, and this red more than 625 is the northeast India, and northwest India, eastern coast, and the southern states of Andhra, Tamil Nadu, and Kerala, they have one of the highest prevalence of stroke. So there are variations of stroke burden in our country. So that completes the global burden of stroke and the burden of stroke in India. What about stroke prognosis? This is very, very important. There's a large community-based data from Oxfordshire, UK. And these are the 4 types of stroke: Lacuna stroke, severe ones like total anterior circulation infarcts, partial anterior circulation infarcts, and posterior circulation infarcts. If you look at the cerebral infarction, that is the ischemic stroke, about 7 to 13% of the patients die and at 1 month, and at 1 year, about 23%. ICH patient, almost half of these patients die at 1 month or 1 year, and subarachnoid hemorrhage, almost similar figures. If you look at the type of ischemic strokes, these are lacunar stroke and tachy, pachy, pocky. So this is the figure. The highest case fatality rate and mortality is in the tachy, which has a total anterior circulation infarct, and the dead and dependent is very high in tachy and pachy. So close to 2/3 of our stroke patients are left disabled, either 1 month, 6 months, or 1 year. So that is the burden of disability that we have due to stroke. So if the disability is very high, after people survive, how to reduce the stroke-related disabilities? And there are many interventions. This table shows the various interventions that can reduce the disability, starting from secondary prevention, stroke unit care, rehabilitation, that is early supported discharge involving the multidisciplinary team, aspirin, use of aspirin within 48 hours, thrombolysis using RTPA, mechanical thrombectomy, hemicranectomy. This slide shows the extra independent survivors in a population of 5 million inhabitants with 10,000 strokes per year. And this, you just focus on this last row where, last column where for each intervention, the number of extra independent survivors. And you look at here, stroke unit has highest number in terms of extra independent survivors if all eligible patients are managed in stroke unit. So what happens in stroke unit? All the acute treatment, secondary prevention, rehabilitation, and multidisciplinary team, everything is coordinated in the stroke unit care. What about the status of stroke services globally? This is again a data from World Stroke Organization. And you can see there are very few stroke surveillance programs, only 16% of stroke units in LMICs, and acute treatment is available only in 26% of the low-income countries, and less rehabilitation services. So we have evidence that stroke unit care improves, multidisciplinary team care improves outcome, but the availability is very, very small in LMICs. So stroke patients, if they are managed in stroke unit, that leads to improved outcome. So what is a stroke unit? Stroke unit is defined as an area within a hospital where stroke patients are managed by a coordinated multidisciplinary team specializing in stroke management. This is very, very important. So why stroke units are effective? There is a focused care of stroke expertise. There is a team approach. There is a multidisciplinary team. You have nurses, the therapists, you have social workers, the families involved, the doctors are involved, the rehabilitation physicians are involved. And from the medical point of view, the factors that worsen outcome are identified very early, and you take precautionary measures or preventive measures and early implementation of secondary prevention strategies, early rehabilitation, and there is a multidisciplinary team. Everybody is motivated. Everybody is focusing on the recovery of the patient, and there is involvement of the family. So these are the factors that make the stroke unit effective. So what is the evidence? This is a Cochrane review from multiple trials. Stroke patients who are managed in a stroke unit, they tend to be alive, living at home, and independent with a long-term follow-up about 1 year. Irrespective of whether the type of stroke is ischemic or hemorrhagic, whether they are old or whether they are men or women, and the effectiveness is seen in all across categories. And if you look at early supported discharges or ESD, where there is an involvement of the multidisciplinary team with the medical professional, nursing, and rehabilitation professional along with the family, what is the evidence? If you have a coordinated multidisciplinary team and you have a clear discharge plan, what will happen to these patients after discharge, then the outcome improves. This is again from Cochrane latest data. So there is evidence that stroke unit care improves outcome, multidisciplinary team, including the early supported discharge, improves outcome. What about in less wealthy areas, LMICs, whether stroke units are effective? This is one meta-analysis that we did in 2012, which was published in Lancet Neurology, where we compiled data of patients who are managed in stroke unit versus patients who are managed in medical ward across all LMICs. And what we see in the forest plot here is it reduces mortality. Patients who are managed in stroke unit in LMICs, it leads to reduction in mortality. This is our own study where we compared patients who are managed in stroke unit versus patients who are managed in medical ward. We can see a gross reduction in complications, mortality, and there is slightly increase in length of hospital stay because of the in-hospital rehabilitation facilities that we had in our center, and rehabilitation access to rehabilitation services also improves. So even in LMICs, we have evidence that stroke unit care improves outcome, but neurologists are not there everywhere. There is shortage of neurologists, shortage of therapists, and so in this scenario, how we can develop model and implement stroke unit care. This is one of the models, a physician-based model that we implemented in our affiliated hospital. Before we implemented the stroke unit care, we collected baseline data for almost a year. Then we identified the area in the hospital where it will be the 6 beds were identified, stroke patients were kept here and managed. And there was an in-house CT scanner. The nurses, the doctors, and the therapists were trained for 1-month training program. And we started implementing stroke unit care, and data was collected. So what did we find? This is the data pre-stroke unit care and post-stroke unit care. You can see the reduction in the complications in the stroke unit, the post-stroke unit care. And if you look at the key performance indicators like swallowing assessment, mobility assessment, evidence of meeting with multidisciplinary team, use of secondary prevention drugs, all improved in the post-stroke unit care. So this is very important, the usage of multidisciplinary team. So there was a reduction in length of hospital stay by about 1.4 days. But however, the outcome, there was no difference. But we are able to demonstrate in a remote area that there is no availability of neurologists, creating a multidisciplinary team with a physician's overview. We are able to show this model. So if we are able to develop a model in LMIC, how we can organize a stroke program. So first of all, you need to have a dedicated area. Try to identify at least 6 beds or 3 to 6 beds. Have some monitors, infusion pumps. The most important thing is a multidisciplinary team. You need to have nurses, doctors, radiologists. You need to have rehab therapists, whoever's available in your area, in your hospital. And of course, the emergency department should be identified. They should be trained. You need to have a radiology staff. But the most important thing is summarized here. You need to have protocols in place for all these parameters. The medical management, swallowing assessment can be done by the nurses to prevent pneumonia, early mobilization, the nurse-driven protocols to prevent complications. All these can be prepared, and it's all readily available. And skills training for all the staff. And the most important thing is the multidisciplinary teamwork involving the family, early supported discharge, clear discharge planning, involving the MDT and the caregivers. So do we have more evidence from other countries? This is what we did call organized stroke care across income levels in South Africa, Uganda, Rwanda, and some centers in India. And this is a team, the OSCALE team. And what we did was we had a similar model in 2 remote areas in India, in Uganda, Rwanda, and South Africa. So the basic method we applied was collect baseline data, train them, and again collect data. So this is called step wedge design, before and after design. In different sites we implemented. So the key performance indicators, as I mentioned in the Teshwood study, so we focused mostly on that, and then we had this multidisciplinary team and the secondary prevention strategies and discharge plan. So this is what we saw in the Indian cohort. This is a forest plot where we can see the swallowing assessment improved, mobility training improved, secondary prevention strategy improved, survival also improved at discharge. The outcome was almost same, but the key performance indicators we are able to show across all the 3 centers. And what about Rwanda? This is how it happened. And you can see here, even in Rwanda, you can see the type of stroke, and these are some of the key performance indicators. I'll just focus on this slide. The swallowing screen improved, and use of antiplatelet drugs and other drugs improved in the post-intervention phase. Mobility training improved. MDT meetings occurred, the frequency increased, and there was definitely the assessment prevention of complications also improved. So this model of care we are able to demonstrate in other continents as well, other LMICs. So coming to the challenges, the one component of the stroke unit care, besides the medical nursing, the stroke rehabilitation part, what are the challenges that we have in LMICs like India? Availability of infrastructure, personnel, training, the community support, etc. Saying what is the current practice in India? You have outpatient rehabilitation, some centers offer in-hospital rehabilitation, home-based rehabilitation, you have community integrations, and most of the patients are discharged to their homes. So in a situation like this, what is the best model? As I had mentioned earlier, you need to have MDT, but also training the family members, the caregivers, with a good early supported discharge plan. So this we tested in a 10 trial, what is called family-led rehabilitation of stroke in India. We started with the pilot trial in India in our center, and we learned a lot of lessons, and by which we are able to implement in the main trial, where we are able to recruit 1,250 patients across 14 centers in our country, where patients were randomized to intervention arm, where the physiotherapists trained the relatives when they were in the hospital with over 3-hour session. And after discharge, they had home visits, and the relatives were supposed to deliver the rehab service, rehabilitation at home, and they documented for 1 month, every day, how many minutes, what all they did. And then at 3 months and 6 months, there were telephonic follow-ups and home visit by the therapist. And 3 months and 6 months, then independent blinded assessor assesses the outcome. So what did we find in primary outcome? There was no difference. And even in all the secondary outcome measures, quality of life and length of hospital stay, there was no difference. What did we learn? We thought this will be a very good model and it will be a positive trial, but it was neutral. So what did we learn? We learned a lot of lessons. One is there was adherence to the protocol. It was very, very high. The early supported discharge could not be implemented because the physiotherapists, when they went to their homes, they were spending more time in counseling and educating them rather than delivering therapy and monitoring therapy. And the process evaluation, what we found was this model of care was acceptable for the patients and relatives, particularly for the rural and the poor population. So we are getting into attempt 2, where we are trying to build in telerehabilitation, and we're awaiting funding to carry out this trial. And what else is important in stroke rehabilitation in India? Adherence to exercises. This is a group in Manipal where they did adherence strategies for exercises. Again, training the caregivers when they were in the hospital, and they and then at discharge, they had session 4 and 5 after they were discharged, and they were able to demonstrate that exercise adherence improved if you use these strategies, and mobility improved. So it is not only the delivery of rehabilitation, but also you need to have strategies that are built in to improve the adherence to exercises. So what about evidence? Yes, there are evidence-based treatment available, but still, I would say stroke rehabilitation is naive, particularly in LMICs. You will come across a lot of challenges, a lot of ideas will come up, but you can come up with generating your own evidence. So one example I'll share. During one of our MDT rounds, our neurophysiotherapist said, "Sir, this patient has neglect." And then I asked the person, what are the current evidences? What are the current therapies available for treating unilateral neglect? So she went and did a review And then we found that a simple technique that we can do is mirror therapy. So we did a RCT, small RCT, but it's a class 1 and level 1 evidence that we have. So what we did a mirror therapy, this is a sham mirror therapy, and this is a mirror therapy. And we are able to show that improvement in neglect by using a simple intervention. Preparing a mirror box is about some 700 or 800 rupees. So yes, we will have a lot of challenges, but we can come up with ideas, and these ideas can be used to test in innovative trials. Then we can generate evidence. Another important thing is many of our patients, they go for complementary and alternative medicines. While they take medication, while they take rehabilitation services, but they also try this, and a good proportion of our patients. So we are trying this in one important trial called Restore trial in Indian Stroke Clinical Trial Network, where we are trying to compare Ayurveda treatment and conventional physiotherapy against conventional physiotherapy. And this trial should get over by middle of next year. So if they are randomized to intervention arm, after 1 month, if they are stable medically, they get this weekly treatment of Ayurveda when they are admitted in Ayurveda center in the hospital. And what are the other ways? So one is the game-based rehabilitation. One of my colleagues, Dr. Gandhi, had got a grant from Wellcome Trust to test this in a game-based rehabilitation, where we came up with remote sensing mouse, which is placed on objects which are used for activities of daily living. And when the mouse moves, they play the games, and you can simple free to download games. And we use outcome measures to document the movement. These are the movements that you can document, and what is normal, what is abnormal can be defined. The problem was it was a feasibility trial, and the trial was not at all feasible in the sense people are not very keen to come every day to come and do this game-based rehabilitation. However, whatever small sample that we had, there was some trend that in terms of improvement in the outcome measures, particularly for the hand and the shoulder movements. So telestroke rehabilitation, with the advent of COVID, and there have been a lot of challenges, as there are some models that are coming up. This is one such model, Care for Stroke, smartphone-based application. And then there is another one called medical application-based post-stroke strategy for stroke survivors. This is a RCT, a pilot trial, which is of benefit, mainly to prevent bed sores, pneumonia, etc. And a larger trial has been funded by Indian Council of Medical Research to be done in the INSTRACT network. Another important challenge is the training. There is no uniform training, particularly for curriculum across PG or UG courses, even in PMR. And new curriculum is needed, and standardization is needed. Short-term fellowships of UGs and PGs are important. And as a policy, in the National Non-Communicable Disease Program, yes, there is a provision to appoint a physiotherapist in the district hospital, but not every hospital has done that. Insurance coverage is very crucial for rehabilitation, which can be incorporated in the Ayushman Bharat assisted devices to buy for the patient, and social benefits. Many people are not aware about the social benefits in our country. So in conclusion, several challenges in delivering stroke rehabilitation in India, but there are low-cost techniques are available. Stroke unit care with multidisciplinary team is the most important thing. And home-based program, telerehabilitation is a way to go forward. And change in curriculum and evidence-based guidelines are very important. We need to definitely test and try complementary and alternative treatments in rehabilitation. And I acknowledge doctors and in my team for all the support, and I acknowledge my comprehensive stroke program team and also the MDT team. Thank you very much.
Thank you, sir. Thank you for the wonderful and informative talk. I just want to ask you one thing. In the recent past, during the COVID times, we emphasize more on telerehabilitation. But considering our population from low income group, these people are not aware of the smartphones or the tablets. So they are completely dependent upon the caretaker, or we require someone, some family member to be with them. So can you throw some light on how do we manage all these problems?
Yeah, it's a major problem. No, if they don't have a smartphone, it is very, very difficult. And so at least in our center, what we are doing, if they have a smartphone, our rehab group, they send videos and they have this WhatsApp call. And we also have a paid stroke rehabilitation services also as part of our telemedicine program. But people who don't have these facilities, there is one provision which people do is they take printouts of some of the exercises and which has pictures, pictorial basically, and try to give to them, and they come for follow-up, and or liaise with anyone, whether it's a caregiver or any other home-based therapist who they have employed, and talk to them and try to help them, over telephone. So this is how we are doing currently.
Yeah, that's a good idea. Thank you, sir.
Thank you, sir. Thank you, ma'am, for the talk. Actually, this gave us much more in-depth knowledge that what are the epidemiological trends that are happening all throughout the world and more so in India. So even as a physiotherapist, it is very much important to understand if in this geographical location there are maybe there are going to be various shortcomings that are going to be there as a therapist and from the end of the patients as well. Um, Thank you, sir, once again.